Welcome back, everyone. This is Dr. Rybinnik. Today, I'm introducing a new kind of video, a clinical consult. The intention here is to learn about a certain topic by analyzing a case. This will hopefully be shorter than my typical video and more interactive. This video is rated MS for medical student due to basic concepts, clear language, and case-based examples. Medical student participation is advised. I have no relevant financial conflicts, and full disclosure, this case was modified and simplified for teaching purposes. Our patient for today is a 56-year-old woman with past medical history of hypertension treated with lisinopril. She was last known well 11 hours ago at bedtime. In the morning, she was found by family to have acute onset comprehension and expression difficulties, right facial droop, right-sided weakness. She could not give us any more history because of aphasia, but family denied her having recent illness, prior thromboembolism, family history of thrombosis, or cardiac disease. To the family's impression, aside from hypertension, our patient was generally healthy. On exam, the patient was mildly hypertensive, but the vitals were otherwise normal. She's awake and alert, but globally aphasic and mute. She does not follow any commands or make any sounds. But she's tracking you with her eyes and making purposeful movement with the left arm. There is a left gaze deviation, and she's unable to cross midline with her eyes. Right homonymous hemianopia, an inability to see in the right field and with both eyes. Right facial weakness, that is upper motor neuron type, meaning lower face is affected, not the forehead. And significant right hemiparesis, with barely some effort against gravity in the right arm and leg. So you're imagining this person with a very severe lesion, globally aphasic with left gaze deviation, right field cut, right hemiparesis, right facial paresis. Okay, riddle me this. What is the likely localization of our patient's lesion? Is it A, the pons, B, the cortex, C, the spinal cord, or D, internal capsule? You probably said cortex. Is this your final answer? Let's see if you're correct. Well done! This is a cortical lesion. Let's break it down. Here's an oversimplification of the motor pathways. Our patient had a right hemiparesis and facial paresis, and that's pictured here in blue. The possible sites of lesions are pictured in pink. First, ask yourself, what is the lowest level in the motor pathway at which the lesion can affect the face? Well, face is controlled by the 7th cranial nerve, with the cell bodies located in the 7th nucleus in the posterolateral pons. So the lesion cannot be below the facial nucleus, otherwise the face will be spared. So general possibilities include the pons, midbrain, internal capsule, corona radiata, or the cortex, frontal lobe. 5 locations. That's way too many for us to consider, and we want to narrow it down. But how? Well, what other deficits does our patient have? Aphasia, field cut, those are typically cortical signs. So if a patient has those deficits in addition to weakness, then the lesion must involve frontal lobe to cause the weakness, and adjacent temporal and parietal lobes to cause the other symptoms. Corona radiata connects the cortex to subcortical structures, so lesions can present with similar symptoms, although generally smaller and milder because the motor fibers are spread far enough apart. Internal capsule lesions can cause sensory disturbance by affecting the nearby thalamus. Midbrain lesions can affect red nucleus, causing ataxia, and cranial nucleus of the third nerve, causing paresis in one eye and maybe enlarged pupil from parasympathetic damage. Pontine lesions can also cause ataxia, but this time from interruption of contralateral cerebellar pathways. Pontine lesions can also cause horizontal gaze weakness because the pontine paramedian reticular formation, the horizontal gaze center, is located in the posterior medial pons. But it's painfully obvious that our patient with aphasia and field cut likely has a cortical lesion. There's one more layer of localization we should consider here: vascular territories and vascular supply. This is an axial cut of an MRI that's been color-coded to approximate the major vascular supply. The patient's looking towards the top of the slide here, and the patient's left is on your right. Medial frontal lobe is supplied by the anterior cerebral artery, pictured here in yellow. The majority of the hemisphere is supplied by the middle cerebral artery, pictured here in red, and the deep lenticular striate branches, pictured in purple. And posterior cerebral artery territory, in blue, rounding out the vascular supply of the medial occipital and inferior temporal lobes. Considering our patient's symptoms, listed here on the left, if the lesion is vascular, what is the likely vascular territory involved? That's right, left MCA. Because the MCA supplies the frontal, anterior superior temporal, and parietal lobes, the list of deficits with an MCA stroke is quite long. Frontal lobe damage can cause contralateral hemiparesis, facial paresis, gaze paresis and expressive aphasia when the dominant hemisphere is involved. Parietal lobe damage can cause contralateral sensory deficits, field cut, and neglect when non-dominant hemisphere is involved. And temporal lobe damage can cause a field cut and a receptive aphasia when the dominant side is lesioned. Okay, now that we fully understand the anatomic and vascular localization of our patient's lesion, what is the pathological differential here? Let me remind you that we are taking care of a 56-year-old woman with hypertension and acute onset global aphasia, left gaze deviation, right field cut, right facial droop, and right hemiparesis. Of course, ischemic stroke is going to be at the top of the list, followed by intracerebral hemorrhage. A large tumor with cerebral edema and mass effect can certainly cause these symptoms. Other pathologies will include seizure with postictal TOTS paralysis and encephalitis. Itis as an inflammation of the brain parenchyma, but that tends to develop over the course of weeks rather than hours. Our patient's airway, breathing, and circulation are stable. What is the next best step in the management? All together now? Head CT. And why? Head CT is excellent at diagnosing or excluding hemorrhage. This is a non-contrast head CT with axial slices through the basal ganglia on the right and midbrain and sylvian fissure on the left. Our patient is facing the top of the slide and the patient's left is on your right. Can you find the abnormality? Pause the video if you need to. The image on the left shows a serpentine hyperdensity outside of the brain in the sylvian fissure. You know that all acutely clotted blood looks hyperdense or bright on CT, so this dense vessel sign represents an acute clot in the left MCA. Now, sometimes a dense vessel sign is artifactual, so it's important to confirm the lesion with a dedicated vessel study, such as the CT angiogram pictured here. This is an axial maximal intensity projection view with the patient looking towards the top of the slide, same orientation as before. What's missing? Where's the middle cerebral artery? It's occluded. Okay, get ready to be puzzled. So now that we know that there's a left MCA occlusion causing severe deficits, what is the primary goal of acute ischemic stroke management? Is it A, to give TPA, B, to diagnose the cause of the stroke, C, to start aspirin, or D, to remove obstruction to blood flow? I'm going to guess you said D. Let's see if you're right. Absolutely! Congratulations! You have to remove the obstruction. The emphasis here is on the moo. Say it with me. Remove the obstruction. Right now, we don't care what caused the obstruction. Treat first and ask questions later. In this illustration, the patient is looking directly at you. Imagine there's a clot in the left MCA, just like in our patient. A part of the MCA vascular territory, usually the basal ganglia and deep subcortical structures which are supplied by the lenticular striate vessels off of the MCA, dies very quickly because it cannot get blood flow by any other means. There's very little collateral blood flow in the deep structures of the brain. That injured brain is called the ischemic core and represents irreversible permanent ischemic damage. Now, the more distal MCA territory is currently being supplied by collaterals from ACA and PCA, but that collateral flow is suboptimal. Think of it this way: if you block a major highway, you can still get to your destination by using side streets, but certainly less efficiently, and it will probably take longer. So, for the moment, this brain is potentially salvageable. This is called the ischemic penumbra. Act fast, and the penumbra will become normal brain. Delay, and the penumbra will become ischemic core. This is precisely the reason why stroke interventions are so timely. Patient arrives at the hospital by ambulance. Within minutes, a stroke code is called to mobilize resources to bring the treatment team to the bedside. By 15 minutes, imaging is completed. And hopefully, by 20 minutes, we are now considering intravenous thrombolysis with tissue plasminogen activator. In cases such as ours, where there's a known large intracranial vessel occlusion, we then consider eligibility for invasive catheter-based procedure called thrombectomy, removal of the clot. By 40 minutes from arrival, basic lab results come back, and by 60 minutes, hopefully the eligible patient is transferred to the cath lab and begins undergoing mechanical thrombectomy. This is a procedure where a catheter is typically inserted in the femoral artery and ascended up the aorta, aortic arch, common carotid, internal carotid, and up to the MCA lesion. And then to remove the clot, we use suction devices or these retrievable metallic meshworks called stents. By the way, with every minute that passes, it's been estimated that a person loses 2 million neurons. 2 million neurons per minute. So imagine I come to the bedside and I say, "Hi, Mr. Smith, I am Dr. Rybinnik. I'm a stroke neurologist here to see you." Me uttering that sentence potentially cost that patient 2 million neurons. So I no longer introduce myself during a stroke code. I do what needs to be done and then talk to the patient and the family. Alright, so what are the indications for thrombectomy? Well, first, the patient needs to have a reasonable baseline neurological function to be able to get back to independence. Second, disabling deficits. You wouldn't necessarily want to subject a person with an isolated facial droop to an invasive procedure. Did our patient have disabling deficits? Oh, definitely. Aphasia, gaze paresis, field cut, hemiparesis. Next, you need a proven large vessel occlusion. You really can't thrombectomize a clot that doesn't exist. And the final criteria is viable brain left to save. This is the most challenging criteria of all, so let's talk about that for a moment. Imagine you have 3 very similar patients who have a left MCA occlusion and at time 0 from stroke onset. You can see that the entire territory of the MCA is being hypoperfused and is marked here in green to illustrate a penumbra. This is what's causing the patient's deficits. The brain is not irreversibly damaged yet. Now, if these patients do not get help within 6 hours, the first patient's penumbra may completely convert to ischemic core, and there will be no brain left to salvage. The second patient may have a core infarction involving half of the MCA territory, and the third patient might still have a very small core. Fast forward to 12 hours from symptom onset. Our second patient may progress to a complete MCA infarction, but the third patient, even at 24 hours, may still have a great deal of salvageable brain. So how do we identify that person? Within the first 6 hours from stroke onset, we can use our clinical skills to identify the so-called clinical to imaging mismatch. You examine a patient, looks like MCA syndrome. You look at the CT scan, and there's no evidence of stroke. So clinical to imaging mismatch. The core infarction would likely be small, and the penumbra is large. Beyond 6 hours, the strategy begins to fall apart. The CAT scan loses the ability of distinguishing what's irreversibly damaged from the tissue that can still be salvaged, and we need help from some advanced imaging. Enter CT perfusion. Injecting a bolus of contrast intravenously and scanning the brain in rapid succession allows the algorithm to calculate the time it takes for the blood to get to the brain and extrapolate cerebral blood flow. On the left are axial cuts with cerebral blood flow less than 30% of normal that are mapped out in pink. Brain tissue that doesn't need 70% of its blood flow is, for all intents and purposes, irreversibly damaged. That's the ischemic core. On the right side, the brain tissue is receiving blood flow, but that flow is delayed. How long does it take for blood from the heart to get to the brain? About a second or so. So Tmax, or the maximum time it takes for blood to get to the brain, over 6 seconds, is severely delayed. That area of Tmax more than 6 seconds is color-coded green, and it's meant to illustrate penumbra. This is our patient's perfusion scan. Does our patient have a mismatch, also known as viable brain tissue left to save? Absolutely. There is a severe mismatch. So what is the next best step in the management? That's right, thrombectomy. So here, the patient's looking at you, the catheter is sitting in the common carotid artery, and contrast is being injected. You see the ICA, then the ACA, but where's the MCA? Occluded. And after the clot has been removed, there's a complete restoration of normal blood flow. This clot unfortunately is not from our patient, but this is what a typical clot looks like. So in this case, complete reperfusion was achieved with thrombectomy. While we're on the subject, in general, how effective is this procedure anyway? You probably heard of the concept called number needed to treat. It's simply the number of patients that you need to treat with your intervention to benefit one patient. So an ideal treatment would have an NNT of 1. Every time you treat a patient, that patient benefits. So let's have you guess some NNTs. Let's say a patient is having ST segment elevation myocardial infarction, and you're administering intravenous thrombolytics to treat that patient. What is the NNT for that procedure? 43. You need to treat 43 patients with a thrombolytic to help one patient. Okay. Let's say you're resuscitating a patient during cardiac arrest, and you give epinephrine. What's the NNT for that procedure? 7. You need to treat 7 patients to benefit one. Now, what about endovascular therapy for acute ischemic stroke? NNT is 2 to 3. You need to treat 2 patients to have one of them return to functional independence. I'm not only talking about saving a life here, I'm talking about a patient who can return to their life and their work. That's incredible. This is one of the most effective treatments in all of medicine. So, now that you know all about thrombectomy and selection criteria, which criteria will disqualify a patient from thrombectomy? Is it A, large core infarction, B, stroke noted on awakening from sleep, but still within 24 hours from time last known at baseline, C, administration of TPA, or D, disabling deficit? I'll give you a moment to think. Large core infarction, you say? Well, let's see if you're right. Correct. Correct. Large core infarction means less brain left to save and high risk of reperfusion hemorrhage. You would be restoring blood flow to necrotic brain with disturbed blood-brain barrier, so arguably the risk-benefit ratio there is not favorable. Reperfusion was successful. Immediate neurological improvement was noted. The gaze deviation and field cut have resolved, and our patient is now following some commands and has some decent anti-gravity strength on the right side. Our patient was admitted to the intensive care unit for observation. So now that we removed the obstruction, what are the goals of care after reperfusion? Well, right after reperfusion, we want to prevent secondary injury, both from the reperfusion itself and from sequelae of stroke, like cerebral edema. So we start with targeted blood pressure management. We don't want to abruptly drop blood pressure in an acute ischemic stroke patient, but if the vessel is open and the patient improves, penumbra was likely converted to viable tissue, and maintaining permissive hypertension will likely put our patient at higher risk of bleeding. So lowering blood pressure to a systolic of 140 to 160 is probably reasonable. Next, for all the previously mentioned reasons, these patients are unstable and need to be monitored in the ICU setting, with frequent neurochecks and groin checks post-procedure. Homeostasis is essential. Treating fever and hyperglycemia increases the chances of favorable outcome. As I mentioned before, strokes can swell, but that usually happens within 3 to 5 days after stroke onset, so it's not an issue at this point. Our goal now shifts to preventing future stroke, actually doing the workup to understand the mechanism of the stroke and addressing it with appropriate therapy. So, our patient had an uneventful 24-hour observation in the ICU and remains neurologically stable. MRI of the brain was done and confirmed a small core infarction without any hemorrhagic transformation. Aspirin was started as a general measure of stroke prevention. How would we actually determine the mechanism of the stroke? For that, let's resurrect the 100-year-old Virchow's triad. It's simplistic but useful. A clot basically forms under 3 conditions: abnormal stasis of blood, which usually means cardiac dysfunction, vessel wall injury, or increased clotting potential in the blood, a hypercoagulable state. So when it comes to stroke mechanisms, just remember heart, vessels, and blood. We can assess blood vessels with non-invasive MR or CT-based angiograms. The heart structure can be assessed by transthoracic or through the chest echocardiogram, or more sensitive but more invasive transesophageal echocardiogram. The left side of the heart that pumps blood to the brain is right up against the esophagus, so transesophageal echo requires swallowing of an ultrasound probe. Looking at the heart structure is not enough, and we have to evaluate heart function, the regularity of heartbeat. We can do that with cardiac telemetry monitoring. And finally, in patients with strong family history or personal history of thromboembolic disease, we can check the blood for hypercoagulability. And in people with suspicion of cancer, malignancy workup may be in order. So, if I may complicate things a bit, ischemic stroke can be caused by disease or injury in large vessels, like MCA, ICA, small vessels, like the unnamed perforators from the MCA stem, cardioembolism, undetermined embolic source. This category used to be called cryptogenic and included patients with stroke in whom the workup was completely negative. We now think that at least some of those patients probably suffer from undiagnosed atrial fibrillation, which is notoriously difficult to pick up, and hypercoagulability. So, what studies do you want to do in our patient? I'll give you a moment. MRI was already done and showed a small acute ischemic stroke in the left MCA territory, which really means that most of the penumbra was converted to viable tissue. Great! You might remember that the CT angiogram which was done during the stroke code showed no evidence of significant carotid artery stenosis. We also know that because we had to cross the carotid artery with our catheter just to get to the MCA lesion. So, no large vessel disease. Telemetry monitoring showed no evidence of atrial fibrillation. LDL, the bad cholesterol, was normal. And hemoglobin A1C, a measure of glycemic control over the past several months, was normal as well. Transthoracic echocardiogram was finally done. Let me orient you. This is a standard 4-chamber view of the heart. The ultrasound probe is positioned at the top of the slide and slices the heart on its long axis. Right and left ventricles are at the top, and the atria are on the bottom. Look at that gigantic mobile mass in the left atrium. What is it, and what do we do about it? Hold that thought. Just one more game. Can you tell me which stroke mechanism generally has the highest rate of recurrence without treatment? Is it cardioembolism, large vessel disease, small vessel disease, or cervical carotid dissection? Did you say carotid dissection? Let's see if you're right. No, I'm sorry, it's cardioembolism. Okay, I'm just joking with you. I know you chose cardioembolism. Crash course in ischemic stroke risk. Let's illustrate it with dog sizes. Small vessel disease is like a French bulldog, mild risk. Large vessel disease is like a border collie, medium risk. And cardioembolism is the German shepherd of stroke risk, high risk. Embolic stroke of undetermined source and other rarer causes are kind of unpredictable, like this little kitten. Sometimes high risk, like with malignancy, and sometimes very low risk, like with carotid dissection. Okay, but I know you're dying to find out what happened to our patient. So we just treated a 56-year-old woman with left middle cerebral artery occlusion. The echocardiogram and the pathology from the lesion we pulled out from the MCA was actually consistent with atrial myxoma. This wasn't a clot at all. This was a piece of cardiac tumor. She underwent an uncomplicated resection of the tumor, and she's doing well. So the learning points in this case are: remember the clinical signs and symptoms of MCA occlusion, including contralateral hemiparesis, field cut, gaze paresis, cortical signs like aphasia or neglect. Differential diagnosis of acute focal neurologic deficit, stroke, hemorrhage, seizure, tumor, encephalitis, and even complicated migraine. Endovascular treatment of acute large vessel occlusion is one of the most effective treatments in all of medicine. Remind me, what were the patient selection criteria again? Right. Reasonable baseline function, disabling deficit, confirmed acute large vessel occlusion, and viable brain left to save. Remember post-reperfusion management to prevent secondary injury, ICU monitoring, blood pressure control, groin checks, neurochecks, monitoring for cerebral edema, ischemic stroke mechanisms and workup, heart, blood vessels, and blood, which means that you need to do at least an MRI of the brain without contrast, non-invasive vascular imaging, cardiac imaging, and telemetry. And that's your clinical consult for today. Feel free to explore the rest of the channel, and I'll see you next time. Bye.